Categories of dementia. 6081 Dementia due to cerebrovascular disease. 6082 Dementia due to Lewy body disease. 6083 Frontotemporal Dementia. 6084 Dementia due to psychoactive substances including medications. 6084.0 Dementia due to use of alcohol. 6084.1 Dementia due to use of sedatives, hypnotics or anxiolytics. 6084.2 Dementia due to use of volatile inhalants. 6085 Dementia due to diseases classified elsewhere. This includes 6085.0, Dementia due to Parkinson disease, 6085.1 Dementia due to Huntington disease, 6085.2 Dementia due to exposure to heavy metals and other toxins, 6085.3 Dementia due to human immunodeficiency virus. 6085.4 Dementia due to multiple sclerosis, 6085.5 Dementia due to prion disease, 6085.6 Dementia due to normal pressure hydrocephalus, 6085.7 Dementia due to injury to the head, 6085.8 Dementia due to pellagra, 6085.9 Dementia due to Down syndrome, 6085.y Dementia due to other specified diseases classified elsewhere. 2. Dementia due to cerebrovascular disease, dementia due to brain parenchyma injury resulting from cerebrovascular disease, ischemic or hemorrhagic. The onset of the cognitive deficits is temporally related to one or more vascular events. Cognitive decline is typically most prominent in speed of information processing, complex attention, and frontal executive functioning. There is evidence of the presence of cerebrovascular disease considered to be sufficient to account for the neurocognitive deficits from history, physical examination, and neuroimaging. Diagnostic requirements. 1. All diagnostic requirements for dementia are met. 2. Dementia is presumed to be attributable to underlying cerebrovascular disease as demonstrated by neuroimaging, medical tests, and/or clinical history of cerebrovascular disease. 3. Diagnostic requirements for Alzheimer disease dementia, mixed type, with cerebrovascular disease are not met. 4. Neurocognitive symptoms often follow cerebrovascular compromise. In stroke, the type of neurocognitive impairment varies depending on the brain regions in which the stroke occurred. Stroke-related neurocognitive impairment typically begins abruptly after a stroke. Improvement in initial neurocognitive deficits is typically seen, with recovery reaching a plateau over time. Residual neurocognitive deficits often remain chronic over time. In contrast, in microvascular events, neurocognitive impairment typically affects so-called subcortical neurocognitive functions, for example, attention, processing speed, and executive/frontal lobe-related functions. If microvascular events are attributed to progressing chronic conditions, for example, hypertension, diabetes, as is common, clinical course of neurocognitive impairment may be slowly progressive. Note, an appropriate diagnosis from the cerebrovascular diseases grouping in the chapter on diseases of the nervous system should also be assigned. 3. Dementia due to Lewy body disease, dementia preceding or occurring within 1 year after the onset of motor Parkinsonian signs in the setting of Lewy body disease. Characterized by presence of Lewy bodies, which are intraneuronal inclusions containing alpha-synuclein and ubiquitin in the brain stem, limbic area, forebrain, and neocortex. Onset is insidious with attentional and executive functioning deficits often present. These cognitive deficits are often accompanied by visual hallucinations and symptoms of REM sleep behavior disorder. Hallucinations in other sensory modalities, depressive symptoms, and delusions may also be present. The symptom presentation usually varies significantly over the course of days, necessitating longitudinal assessment and differentiation from delirium. Spontaneous onset of Parkinsonism, within approximately 1 year of the onset of cognitive symptoms, is common. Diagnostic requirements. 1. All diagnostic requirements for dementia are met. 2. Dementia is presumed to be attributable to underlying Lewy body disease as demonstrated by neuropsychological test data, neuroimaging data, genetic testing, medical tests, family history, and/or clinical history. 3. Clinical history involves the presence of 2 or more of the following symptoms. Recurrent visual hallucinations, typically well-formed. Episodic confusion. REM sleep behavior disorder. 1 or more features of Parkinsonism, for example, resting tremor. 4. Neurocognitive symptoms are progressive and often involve relatively greater impairment in visuospatial skills, attention, and executive functioning, as opposed to primary memory impairment, as is seen in Alzheimer's disease. 5. Additional clinical features may include repeated falls, syncope, hallucinations in other sensory modalities, delusions, and autonomic dysfunction, for example, constipation, urinary incontinence, etc. Note, a diagnosis of 8A22 Lewy body disease should also be assigned. 4. Frontotemporal dementia. Frontotemporal dementia, FTD, is a group of primary neurodegenerative disorders primarily affecting the frontal and temporal lobes. Onset is typically insidious with a gradual and worsening course. Several syndromic variants, some with an identified genetic basis or familiality, are described that include presentations with predominantly marked personality and behavioral changes, such as executive dysfunction, apathy, deterioration of social cognition, repetitive behaviors, and dietary changes. Predominantly language deficits, that include semantic, agrammatic/nonfluent, and logopenic forms, predominantly movement-related deficits, progressive supranuclear palsy, corticobasal degeneration, multiple systems atrophy, or amyotrophic lateral sclerosis, or a combination of these deficits. Memory function often remains relatively intact, particularly during the early stages of the disorder. Diagnostic requirements. 1. All diagnostic requirements for dementia are met. 2. Dementia is presumed to be attributable to underlying frontotemporal disease or atrophy, as demonstrated by neuropsychological test data, neuroimaging data, genetic testing, medical tests, family history, and/or clinical history. 3. Frontotemporal dementia variants include primary progressive aphasia, logopenic, semantic, and agrammatic subtypes, behavioral frontotemporal dementia, and motoric frontotemporal dementia, corticobasal degeneration, progressive supranuclear palsy, and amyotrophic lateral sclerosis. 4. Frontotemporal dementia is progressive, with variants identified based on initial symptoms. Frontotemporal dementia, behavioral variant is characterized by personality changes, often including apathy and progressively inappropriate social behavior. Neurocognitive functioning may be preserved in the early stages, though may later involve deficits in executive functioning, for example, planning, problem solving, with comparatively intact memory skills. Another variant, primary progressive aphasia, is characterized by progressive impairment in language skills, initially in the absence of impairment in other cognitive skills. Subtypes of primary progressive aphasia are often determined based on neuropsychological/cognitive testing, clinical presentation, and sometimes neuroimaging, and are characterized by primary deficits in word finding, logopenic subtype, word meaning, semantic subtype, or word production, agrammatic subtype. Frontotemporal dementia, motoric variant involves progressive impairment in motor functioning, sometimes in the context of progressive neurocognitive impairment, typically characterized by impairment in attention, executive functioning, and visuospatial skills, with comparatively intact memory skills. Frontotemporal dementia, motoric variant can include progressive supranuclear palsy, for example, poor balance, frequent falls, and horizontal gaze palsy, etc., corticobasal degeneration, for example, limb apraxia, tripping, rigidity, and dystonia, etc., and amyotrophic lateral sclerosis, for example, muscle weakness and atrophy, fasciculations, and spasticity, etc. Note: a diagnosis of 8A23 frontotemporal lobar degeneration should also be assigned. 5. 6D84 Dementia due to psychoactive substances including medications. Dementia due to psychoactive substances including medications includes forms of dementia that are judged to be a direct consequence of substance use and that persist beyond the usual duration of action or withdrawal syndrome associated with the substance. Dementia due to psychoactive substances including medications, 6D84.0 Dementia due to use of alcohol, 6D84.1 Dementia due to use of sedatives, hypnotics or anxiolytics, 6D84.2 Dementia due to use of volatile inhalants. 4. Specific substances are known to be capable of producing dementia. If the specific substance inducing the dementia has been identified, the corresponding diagnostic category should be assigned. Note: a diagnosis corresponding to the pattern of use of the relevant psychoactive substance, i.e., harmful pattern of psychoactive substance use, substance dependence, may also be assigned. Thanks for watching. Please like and subscribe.